morning, everyone. It's nice seeing you here. Thank you for making our time to join this presentation, and I hope you enjoy it. So the paper I present today is co-authored with my PhD supervisors, Alex and Nick, where we explore health shock and household portfolio choice in rural China. So I will start with a brief introduction on the background information, the literature review, just a brief literature, and our motivation to do this research and its contribution to the literature. And then I'll briefly highlight our hypotheses, our data, and the methods. And after that, I will show you the empirical results and our conclusions, as well as the policy implications. Okay, so now let's start. So as we know, population aging has become a major challenge globally, and one of the biggest shocks faced by elderly people is illness. And this has attracted a lot of attention from the policymakers and the scholars about the economic implications of health shock and poor health. So here we go. So prior studies have shown that health shock and poor health is related to safer portfolio choice. For example, if someone experienced health shock, then they tend to hold less risky assets and shift to safe assets such as bank deposits. But most of these studies focus on developed countries. So what is it like in developing countries? Actually, studies show that health shock can affect households' financial situation more severely for low-income households from developing countries, where there's a low level of financial inclusion and an absence of adequately protective health insurance. So these people, most of these people may hold all of their financial assets in the form of safe assets, and they may even hold all of their safe assets in the form of cash at home under the mattress. So, but the scanned paper looks at health shock and portfolio choice in the developing countries, failed to take this into consideration. So that's also one of our contribution of this research. So in this research, we focus on a developing country, China, because first, it has the world's largest aging population, and second, it has low levels of financial inclusion, with around 20% of Chinese adults do not have a bank account. And third, it had several different public health insurance schemes, which differs in coverage and the reimbursement policy, which provide us good context to explore how the protectiveness of health insurance can alter households' financial behavior. And our study mainly have three contributions to the literature. So first, as I mentioned, most of prior studies focus on developed countries and households' risky asset holding. And we are looking at the relationship between health shock and portfolio choice in developing countries, and from the cash holding perspective, which is more realistic because in developing countries, only a small portion of the population hold risky assets. And the second contribution is more technical, it's all about econometrics. And I will not go over details here. So we exploit a dynamic framework to capture the initial conditions and the state dependence of cash holding, the individual and household characteristics, as well as cash holding. Okay. So third, we explored two unique indicators for the associations between health shock and portfolio choice, which is the bank presence in the village and the type of reimbursement. So these two mitigators haven't been explored in the literature. So that's our contributions to the literature. And before our empirical analysis, we made three hypotheses. The first one is twofold. It says, if you experience a health shock, then you're more likely to hold only cash in a safe asset, and you tend to hold a higher proportion of safe assets in cash. So remember that in our study, we focus on the middle-aged and the aged elderly people in rural China. Okay? So the hypothesis is made based on the fact that in China, we don't have an NHS, and people have to pay part of the medical costs by themselves. And since in this study, we focus on the middle-aged and elderly people living in rural villages where there is often no banks there, and cash is still a dominant way of daily payment. So in this case, if people get ill, it's safer for them to hold in cash compared to holding bank deposits, so that when they need to, for example, when they need to pay the doctor suddenly, they can pay by cash straight away, rather than traveling to another village or the nearest city with a bank to get the money and get back to pay the doctor. That would be very time-consuming and also costly. Okay, so that's how we make our first hypothesis. And based on what I just said, yes, so we expect the coefficients on health shock indicators to be positive. We can find it in the empirical results section. Okay, so we also made two other hypotheses. The second one is the link between health shock and cash holding is stronger in villages without bank. Because if you live in a village without bank and people experience health shock, then they are very likely to hold a large amount of money to pay for potential medical costs. But if you live in a village with bank, it will be much easier to withdraw money from bank or pay by bank card. So there's no need for this person to hold that large amount of money. So that's how we make our second hypothesis. And the third hypothesis is that the relationship between health shock and cash holding is stronger for people who cannot get immediate reimbursement. So in our data, around 36% respondents enjoy immediate reimbursement. This means when they pay the medical costs, they only need to pay part of it, which is the total costs less the part covered by the insurance. While the other people have to pay the full costs and then receive the reimbursement much later. So for this kind of people, the association between health shock and cash holding may be stronger because their health insurance is less protective. So they're more likely to be affected by health shock financially. Okay, so that's our three hypotheses. And yeah, so if the second and third hypothesis hold, we expect to find the coefficients on health shock to be positive and larger in magnitude for those who live in a village without bank or who cannot get immediate reimbursement because they seem to be less protected. And our data comes from 3 waves of China health and retirement longitudinal study, and it focuses on people aged over 45. And in our study, we focus on the rural respondents, which count for around 60% of the CHARLS data. So we constructed 2 variables for cash holding. The first one is a dummy variable, which equals 1 if respondent hold only cash as safe asset and 0 otherwise. And we also have another variable, which is a fraction. It is calculated by cash, the amount of cash over cash plus bank deposit. So that's the proportion of cash held in safe assets. And we also have 3 health indicators, 3 indicators for health shock. So the first one is a subjective measure. It is a dummy variable which equals 1 if people think that their health is getting worse in the past 2 years. And in our data, around 47% of people think that they have experienced a health deterioration in the past 2 years. And also we have 2 objective measures for health shock. One of them is the new severe dummy. So it equals 1 if respondent has been diagnosed a new onset of acute conditions in the past 2 years. And the acute conditions include cancer or heart attack or stroke, etc. And we also have a dummy variable indicating which equals 1 if respondent has been diagnosed a new onset of chronic conditions in the past 2 years. So the new minor conditions, the minor conditions including hypertension, dyslipidemia, or high blood sugar. So that's all the minor conditions. It's more chronic, more about chronic diseases. And the few pages, the next few pages introduce our econometrics methods. So it's all about econometrics and maybe boring for most of you. So I will just go briefly about the control variables we used in our model. So in our model, we include mainly two sets of control variables, apart from the health shock, apparently. So the first set is a vector of time-varying regressors, including age and hukou dummy. Hukou is a registration system in China, and marital status, educational achievement, employment status, cognitive ability, engagement in social activities, household size, house ownership, financial assets, and net income in real terms, and also household possession of mobile phone and computer, which we take them as proxy for digital payment. And also we include type of reimbursement for healthcare expenses. And we also include the initial conditions of all these time-varying regressors. And we also have a set of time-invariant regressors, such as the gender and presence of bank in the village, which do not vary across time. So that's our model. So for brevity, I will, in the empirical section, for the models with the dummy variable as dependent variable, I will call them probability model. And for the models with cash ratio as a dependent variable, I will call them cash ratio model. So we estimate the probability model using a random effect probability model, and for the cash ratio model, we estimate fractional response models. So here comes our baseline results. The dependent variable is PR cash. It's a dummy variable which equals 1 if you hold only cash in your safe assets. And each of the column shows the estimates for the model for each of the health shock indicators. So for example, the first column is estimates when we have the first health shock indicator worse health in the model. And the second one is for the new severe conditions. So we find that only the severe conditions, only the marginal effect for the new severe conditions is significant and is positive, which means if you experienced a severe health condition in the past 2 years, then you are 3.29 percentage points more likely to hold only cash in your safe assets. So it seems to support our first hypothesis. And then let's move on to the baseline model with the dependent variable as cash ratio. So again, each of the column is for each of the health shock indicators. And again, we find only the marginal effect of new severe conditions. It's significant. That means if you experienced a severe health condition in the past 2 years, then you tend to hold a higher proportion of your safe assets in form of cash. So the results from this table and the last one shows that our first hypothesis hold. That is, if you experienced a severe health condition, then you're more likely to hold only cash as safe assets, and you tend to hold a higher proportion of cash in your portfolio. Okay. And Remember that our third hypothesis is that if you live in a village without bank, then the relationship between health shock and cash holding will be stronger. So in this table, we estimate the marginal effects of health shock for those who live in a village without bank, which is reported in the first row. And we also report the marginal effects for people who live in a village with bank, which is reported in the second row. So it seems that for both the probability and the cash ratio model, only the marginal effect of the new severe conditions are significant and positive, and this is only for people who live in a village without bank. So that means if you experience the health shock and you live in a village without bank, then you're more likely to hold only cash and you tend to have a higher cash ratio. However, if you live in a village with bank, then there seems to be no effect of the health shock on your cash holding. Okay, so this supports our second hypothesis. And we report the estimates for people who who cannot get immediate reimbursement in the first row. So this is the marginal effect of health shock for people who cannot get immediate reimbursement. And the second row reports the estimates for people who enjoy immediate reimbursement. So again, we find that the new severe domain is only significant for people who cannot get immediate reimbursement. That means the relationship between health shock and cash holding is stronger for people who cannot get immediate reimbursement. So that supports our fourth hypothesis. So now let me just briefly summarize our conclusions. So based on a wide range of specifications, we find that people who have experienced health shock are more likely to hold only cash and hold higher proportion of cash in their safe assets. And these relationships are mitigated for people who live in village with banks or for people who can get immediate reimbursement. So these findings, so here comes our a brief policy implications. So if the government reduce the out-of-pocket costs associated with healthcare, or that the local governments make sure that the healthcare expenses can be reimbursed immediately, or that the government can enhance financial inclusion by increasing the number of bank branches in the villages, then the Chinese people could have less incentives to save in the form of cash, and this cash can be put in the banks and circulate in the economy and make them more useful for the economy. Okay, but note that the health shock we analyzed in this study are those that happened to individuals. But the recent COVID-19 is another story. It not only affects those who contracted the disease, but also those who didn't, as in many places we experienced lockdown and the slowdown of the economy. So though in China, the treatment for COVID-19 is free during the breakout of the pandemic, and it didn't cause surge in medical costs, it did cause income loss and bring huge uncertainty to the economy, and the Chinese people may even want to save more. Apparently, this would be really problematic given the already high saving rate in China. And apparently, China needs more consumption, especially nowadays when it cannot rely on exports as much due to the new Cold War between China and the US. But in UK, things are exactly the opposite. According to data from OECD, in the UK, people almost don't save. The saving rate is only less than 1. But studies show that during the pandemic, UK households suffered from around 8% loss of income or even unemployment, and the issue is particularly severe for the bottom income quintile. So if you have enough savings, you will be fine and you can still handle it for a while until things get back to track. But if you don't, it can be very frustrating, and many people turn to financial assistance from parents or friends, or they have to borrow from banks or apply for universal credits, which also bring a sudden burden to the whole fiscal system. So, and in sharp contrast to the low saving rate in UK is a high penetration rate of bank accounts. And according to an FCA report, in 2018, only less than 2% of UK populations are unbanked. And even though the government has launched some schemes to help people to save, the schemes may not work for a small portion, may only work for a small portion of the population, and is not as effective. So it looks urgent for the UK government to find an effective way to stimulate people's incentives to save. So our findings in this study with regards to the bank presence may shed some light to the UK's context. According to the data from the Global Economy website, the number of bank branches per million people in UK is 2.5. This is a number from 2013. And this number of bank branches per million people ranks only in the second half among the 41 European countries. So maybe the government can start from increasing the number of bank branches, and this would be a particular benefit for the middle-aged and elderly people because they rely heavily on traditional. Almost half of them do not use online banking. So I may have talked too much. It's already 11:30, so I think it's a good point to stop. And thank you for listening to my presentation, and all kinds of comments and questions are very welcome. Okay, thank you.